Welcome to SARC Talk Journal Club, where we take a closer look at the research shaping the future of sarcoma care. In each episode, we'll discuss recently published studies, break down the findings, and explore what they mean for clinicians, researchers, patients, and advocates. Along the way, we'll be joined by experts from across the sarcoma community and sometimes even the authors behind the research. Whether you're keeping up with the latest science or looking to better understand the evidence driving sarcoma care, we're glad you're here.
Welcome to SARC Talk Journal Club. This is our first episode, so we're looking forward to everybody engaging with us. And our co-host today is Dr. Catherine Wilbur. She's a medical oncologist, sarcoma oncologist at Johns Hopkins. Welcome, Catherine.
Thank you. It's a pleasure to be here. I'm excited for our first journal club.
Yeah, we've been working through the little details, so hopefully everybody will give us a little grace. Our first episode is on the Cabozantinib and Temozolomide study here. And as we go through it, Dr. Wilbur will be presenting the article and we'll be asking her questions. So with that, Dr. Wilbur, let's go with the first journal article.
Perfect. Thanks. So this is Cabozantinib and Temozolomide in patients with unresectable or metastatic Leiomyosarcoma or other soft tissue sarcomas. So this was a multi-center study that was published back in February of this year in the Lancet Oncology. So today we'll go through the background and rationale, we'll go through the clinical trial design and the results, and then really discuss the impact, the outstanding questions, and the next steps. So soft tissue sarcoma, as we know, is a rare tumor of the mesenchyme. We see about 14,000 cases in the United States, per year. And leiomyosarcoma is one of those subtypes that really accounts for about 10 to 20% of all soft tissue sarcoma. The 5-year overall survival, though, for unresectable or metastatic disease is only about 15 to 20%. Generally, anthracycline therapy is what we consider for treatment, but it does have substantial toxicity, really limited efficacy. And so we know that novel agents and novel combinations are urgently needed. When we think about the scientific rationale of this study, we know that VEGF drives angiogenesis in soft tissue sarcoma and leiomyosarcoma. There have been previous studies that have shown that high VEGF is associated with a worse prognosis. And then we also know that the MET pathway plays a key role in angiogenesis and proliferation and in invasiveness and overall metastasis. And so cabozantinib has multiple targets and is a tyrosine kinase inhibitor. So it inhibits, VEGFR2, MET, AXL. But when we look at cabozantinib just alone for treatment of soft tissue sarcoma, we see that response rate is somewhere between 6 to 11%. Temozolomide is an alkylating agent and is the other drug that was used in this study. It inhibits the DNA repair process and so creates apoptosis. The single agent activity for Temodar is really somewhere between 3 to 18%. There was a preclinical study that actually looked at both of these drugs in combination and found that there was profound growth inhibition when the combination was used compared to either drug alone. So with that information, the authors hypothesized that dual targeting of VEGF and MET with cabozantinib combined with the DNA damage temozolomide would be active and tolerable in unresectable or metastatic leiomyosarcoma, as well as other soft tissue sarcomas. This was a multi-center, single-arm phase 2 trial. There were 5 academic centers, academic sarcoma centers of excellence in the Midwest that were involved in this study. It was a Simon's 2-stage design for cohort 1, which we'll get into in just a little bit. But the key eligibility for this trial were patients had to be 18 years or older. They had to have an ECOG performance status of 0 or 1. They could have had anywhere from 0 to 5 prior chemotherapy regimens. And so I think what's notable about this is that treatment-naive patients were actually eligible to enroll. And then patients needed measurable disease per RECIST. They needed good organ and marrow function. Just because of the nature of how cabozantinib and Temodar work, anyone who had major surgery within the past 2 weeks, who had uncontrolled hypertension, or who had stroke within the prior 6 months were excluded from the trial.
As you think about this, Dr. Wilbur, there were 2 cohorts, and I know you'll get to that.
Yes.
Maybe you can describe for us why it's important to separate these 2 cohorts, or why did the authors decide to do that?
Absolutely. So the cohort 1 is all leiomyosarcoma, so both uterine and non-uterine. But as we know, sarcoma has over 100 different subtypes. And so when we try to think about these results and sort of think about the applicability, right, it's very nice to have this homogeneous population, as the really primary endpoint and sort of the primary group that we're looking at to be able to really assess the efficacy of this combination.
The assignment 2 design was only for cohort 1. Can you describe how the authors thought about cohort 2?
Absolutely. So cohort 2 is really an exploratory cohort. And so they enrolled any non-leiomyosarcoma soft tissue sarcoma. So they enrolled angiosarcoma, liposarcoma, UPS, MPNST, synovial sarcoma. And so really, there was no formal hypothesis testing for this cohort, but it was really just to see if there was sort of early signaling within the cohort.
Yeah. And we'll just call out the 5 U.S. academic sites. It's called the Midwest Sarcoma Trials Partnership. So that's the group. And to be transparent, where Mayo Clinic is also part of the Midwest Sarcoma Trials Partnership. So let's continue on.
The study schema. So again, all patients were screened. We'll go into the design in just a little bit, but the safety lead-in was for 14 patients. And then we had cohort 1 and cohort 2. The treatment cycles were 28 days. And so cabozantinib was dosed continuously at a dose of 40 milligrams. And then the Temodar was at 150 milligrams per meter squared on days 1 through 5 of cycle 1. And then if patients tolerated cycle 1, they were escalated to Temodar at 200 milligrams per meter squared on days 1 through 5 for the subsequent cycles. And that decision to escalate was really based on, the presence or absence of neutropenia or platelets. So if the absolute neutrophil count was 1.5 or greater, then they escalated. And as long as the platelets were 100,000 or greater, they were escalated. Patients then, while they were on treatment, had either CTs or MRIs at 6 weeks after starting treatment, and then 12 weeks, and then subsequently every 8 weeks after that. Patients were allowed to continue on treatment until either disease progression, unacceptable toxicity, or the patient wanted to withdraw or the physician recommended withdrawing.
Dr. Wilbur, can you comment a little bit on the dose schedule of the temozolomide? They used 150 milligram per meter squares days 1 through 5. There are other regimens that use more of a daily dosing, like 4 weeks in a row with 2 weeks off. Just some thoughts on your practice as you think about how you use temozolomide, and reflect a little bit on, is that cabozantinib dose 40 milligrams typical?
Yeah, so these definitely were lower doses. Typically with our Temodar, we are, at least for soft tissue sarcoma, we are thinking about more continuous dosing. Just based on the prior data that we have. And so this dosing, kind of the bolus dosing on days 1 through 5, is used in other cancer types. And so I think just given the concern for sort of toxicity rate, that it makes sense sort of why they decided to move forward with those doses. Is there anything else in your practice?
Yeah, well, to your point, we typically don't use the 5-day regimen as a single agent, but it can be used, and a lot of people do it. We tend to use a continuous if you use temozolomide. However, there's a lot of delayed myelosuppression with the use of that continuous. And the cabo dose is a good hefty dose at 40 milligrams when you combine it there. And we'll get into the toxicity follow-up. So thanks.
When we think about the endpoint, so the primary endpoint was the 12-week progression-free survival for just cohort 1. The secondary endpoints were objective response rate, which is the number of patients who had a complete response. So essentially resolution of disease, or partial response, which is a decrease of 30% or more in their disease burden per RECIST. They also looked at clinical benefit rate, which is the complete response, partial response, as well as stable disease. And then they looked at median progression-free survival, median overall survival, safety, and quality of life. There were exploratory endpoints that were initially planned, but were not kind of ultimately analyzed or published. So they did want to correlate the progression-free survival and overall survival with circulating concentrations of sort of a number of biomarkers, including VEGF, MET, VEG-C, VEG-D, soluble AXL.
Dr. Weber, can you comment on the appropriateness of the 12-week progression-free survival, and whether this was an investigator decision, or was this a blinded independent radiology review?
So I think this is a great endpoint. Really, it's our standard when we think about a Simon two-stage design, especially in sarcoma. In 2002, there was sort of a meta-analysis that was published that looked at sort of what the sort of best 12-week progression-free survival might be. And so, the goal here was that, it would be around 39% if we were to see kind of true efficacy versus sort of that null hypothesis of 20%. So I do feel that is fairly well established within the literature. And then it was by blinded independent central review.
Got it. Just to clarify, as we get into it, we talk a lot about the Simon two-stage design, and we use it quite a lot in just looking at responses and deciding how to do it. And maybe you can share with our group here kind of what a Simon two-stage is.
Yeah, absolutely. So the Simon two-stage is really our gold standard. And so what this does is that it allows for early stopping and sort of an analysis kind of early on in order to protect patients, to conserve resources. And so what happens is there's two hypotheses. There's really the unacceptable response rate, and then there's the target response rate. So stage one of this design is, you enroll a pre-specified number of patients. If your responders are kind of less than that pre-specified number, then you stop early for futility. But if it's greater than that pre-specified number, then you proceed to stage two. And then for stage two, you enroll sort of your total that you had planned for the trial. When we think about it for this particular stage, their kind of stage one kind of plan was to enroll 14 patients. And so to assess that progression-free survival at 12 weeks, their stopping rule within the study was 3 or fewer successes, and they would stop for futility. But if there were 4 or more, then they would continue on to enroll an additional 28 patients. So really looking for a total of 42 patients with leiomyosarcoma. The null hypothesis was in this study was that the progression-free survival at 12 weeks would be only 20%. And then the target hypothesis was that the progression-free survival at 12 weeks would be 39%.
Just to clarify, Dr. Wilbur, too, I just went back and looked at the article just to remind myself. Yeah. This was investigator determined progression-free survival. So it wasn't a blinded independent radiology review, but in this Simon 2 stage, for those that had leiomyosarcoma, you needed at least 4 responses in the first 14 patients to move on. Is that correct?
Yes, that's correct.
Perfect.
All right. So the patient characteristics, there were 42 patients enrolled in the leiomyosarcoma or cohort 1. And then there were 30 patients who were enrolled in cohort 2. So any other soft tissue sarcoma. Within the leiomyosarcoma cohort, the median age was 59. Majority of these patients were women, so 31 or 74%, which really makes sense because there were 24 patients or 57% who had uterine leiomyosarcoma. Compared to 18 patients or 43% with non-uterine leiomyosarcoma. Patients who were treatment naive, there were 12% within the leiomyosarcoma cohort. And then about a third of patients had received 2 prior lines of treatment, and another third had received 3 or more prior lines of treatment. When we look at the cohort 2, so other soft tissue sarcoma, that median age was 63. There were 37% female within that cohort, so certainly lower than our leiomyosarcoma cohort. And then about 40% of patients had received 2 prior lines of therapy, and 40% had received 3 or more prior lines of therapy. When we look at the different histologies that were enrolled, there were 6 patients or 20% who had liposarcoma, and then there were 5 patients or 17% that had a diagnosis of angiosarcoma that were enrolled. And then the remaining were sort of a mix of different histologies. This study did meet its primary endpoint. So the 12-week progression-free survival was 74%. The median progression-free survival for the entire leiomyosarcoma cohort was 6.3 months. And then when the authors break that down by non-uterine and uterine leiomyosarcoma. So it was 6.5 months progression-free survival for the non-uterine leiomyosarcoma, and then 4.6 months for uterine leiomyosarcoma. Within cohort 2, so sort of all different subtypes of soft tissue sarcoma, that median progression-free survival was 3 months. And then as we move on to our overall survival, so that median overall survival for the leiomyosarcoma cohort was 19.2 months. And then within the second cohort, so kind of all comers, the median overall survival was 7.7 months. When we looked at overall survival rate at 24 months, that was 36.4% in cohort 1, and then it was 16.8% in cohort 2. The objective response rate was 17% within cohort 1. So there were 7 patients who had a partial response, so meaning 30% decrease in tumor burden or more. And then that clinical benefit rate at week 12 was 64%, so 27 patients. And then within cohort 2, we saw an objective response rate of 7%. So 2 patients had that decrease of 30% or more. Interestingly, both of those patients had angiosarcoma. And then the clinical benefit rate at week 12 was 43%. That did include patients with stable disease. And so when we look at sort of the different subtypes, it did include patients with dedifferentiated liposarcoma, synovial sarcoma, and then another angiosarcoma as well.
Dr. Wilbur, as you look at this cohort, you kind of described the team felt as though that this was just kind of like, let's figure out and see what was available in there. Other than the angiosarcoma, they do have a nice graph, or you have a nice graph here showing the waterfall plot, showing there are some histologies in there that did not quite meet the, RECIST criteria for 30%, but did have some shrinkage. Was there anything that stood out in your mind as you were looking at this?
Yeah, absolutely. So I think we can see that the dedifferentiated liposarcoma, they were between that 0 to 30%, but certainly had a decrease as well. There's a fibrosarcoma in there, and then the solitary fibrous tumor, as well. I think there were 3 that looked like they had technically a stable disease, but a decrease in sort of tumor burden. So I thought that was interesting as well.
Yeah. It's hard for us to tease out what component the cabozantinib had or the temozolomide had, but yeah, interesting. So it's a great graph to kind of see where potential next studies would be. How was the safety of this combination?
So, overall, I think it was well tolerated. We did see that 99% of patients had at least a grade 1 adverse event. About 50% of patients required a dose reduction, but only 6% of patients, discontinued their treatment, and there were no treatment-related deaths. So really, majority of what we were seeing were sort of grade 1 or grade 2. We did see, as expected, the platelet count decreased. So 40% of patients had a grade 1 or grade 2 thrombocytopenia. There were 19% of patients with a grade 3 thrombocytopenia, and then 11% of patients with grade 4. And I would say that was sort of the most common adverse event that we saw. We did see. Oh, go ahead.
Well, I was just going to say, when you're looking at this, was there any unusual side effects or these are the typical side effects that one would see with temozolomide and cabozantinib?
Yeah, absolutely. There were no new safety signals identified. So I think, what we do see, hypertension, nausea, diarrhea, vomiting, we do expect all those side effects, or we certainly can see those side effects with Temodar and cabozantinib.
We do want to make sure that people have a good quality life, and this study did include a quality life. And how would you see that?
Yeah, absolutely. So I thought that was a really interesting and unique part of this trial. They asked patients to complete a quality of life survey at baseline and then kind of throughout different time points through cycle 3. So what they found is that 99% of patients completed the baseline survey. About 2/3 of patients completed the surveys, up to through cycle 3. It was interesting that patients who responded had a higher baseline physical functioning kind of status, and then an overall kind of global health status as well. We did see that sort of appetite loss, financial problems were less common in the patients who responded. But the common symptoms like GI symptoms, fatigue, appetite loss, those were pretty equal between responders by age, by sex. But I think kind of the big takeaway that the authors point out is that this baseline quality of life actually may be really important as predictors of response as we look at future studies.
It's independent of everything else and performance stats, et cetera. So how well they physically feel when they start this study is how they might respond. So it's interesting and it's something to look forward to. So as you look through this, what are some of the summary and impact statements that you were thinking about?
I think, most importantly, it did meet its primary endpoint. So cabozantinib and Temodar led to a progression-free survival at 12 weeks of 74%. So really exceeded the target of 39%. We did see the median progression-free survival of 6.3 months within the leiomyosarcoma. So really, this is the highest reported in the second line landscape versus the TKIs and the alkylators alone. The 17% objective response rate in leiomyosarcoma was great to see, as well as that clinical benefit rate of 64%. I think this is particularly meaningful because many of these patients are pretty heavily pretreated. And so being able to kind of, at least give them a decrease in size or stability is really important at that point. And then I think the other thing is that this is fully oral. This is an outpatient regimen. It was tolerable. There were no new safety signals. And so I think the quality of life aspect is also really important, sort of thinking about, how we can best support our patient. Within cohort 2, certainly the angiosarcoma signal was pretty exciting. And so I think that's something that, kind of warrants additional investigation. And then I know we touched on it a little bit, but just thinking about that baseline quality of life and sort of physical functioning score and how that might help us, predict our responders and kind of play a role as we select patients for this treatment.
What are your conclusions?
So I think there were a lot of strengths within this study, right? Cohort 1 being this homogeneous population, where we really had strong takeaways. It was very well designed. There was a pre-specified stopping rule. I think, this is a tolerable and a safe oral option. And I think certainly the incorporation of quality of life metrics was important. I think there are a number of questions, that we can ask moving forward. First of all, are there plans for the biomarker analysis? I know it was, initially sort of proposed in the trial, but it certainly would be interesting to see. I think the other question is, do we move this to a randomized phase 3 trial? And then really kind of getting a better sense of the leiomyosarcomas versus the uterine leiomyosarcoma. And of course, just being able to kind of look back at that long-term durability as we kind of get farther out.
In your practice now, this is out there now. This has been published. If you have somebody that wants an all-oral regimen and they're not a candidate for maybe doxorubicin, trabectedin, or have already done that in the leiomyosarcoma realm, how would you position this compared to a single agent treatment?
So I think as long as the patient has, a good performance status, can sort of tolerate doublet therapy, I certainly would consider this, above a single agent. I do think we'll have to kind of carefully consider what patients we are, using this in, but I think it's an excellent option. I do have a patient who she progressed on 2 lines of prior therapy, but she has a great performance status. She's on the younger side. And so, I'm working to try to get this treatment for her. So I think it's very exciting.
Yeah. As we think about this, and I think the study team, and maybe we'll have Dr. Munga and the Midwest team come back for a follow-up, is, we would love to have funding to help support the biomarker. But Catherine, what phase 3 would you actually propose? That's the hard part, because this is a thing in flux right now.
I know. It's a great question. I don't know that I have the answer, but I think, it's certainly, we've had great data, right, in terms of first line with LMS04 and doxorubicin. I know it would certainly be a tough call in terms of what we randomize against. So I think that would be kind of the highly debated aspect of a phase 3 trial.
Well, Dr. Wilbur, thank you for walking through this cabozantinib temozolomide study by Dr. Munga et al. From the Midwest Sarcoma Trials Partnership. That was from Lancet Oncology, published in February of 2026. We are more than willing to have people make comments, and then we'll have a follow-up, podcast on people's comments to this journal club, which is our first one. Dr. Wilbur. So thank you again. Any final thoughts on this study?
I mean, I'm excited to see this kind of move into clinic and kind of, be able to use it more and sort of get some experience with it. So I think really, well done. And it certainly offers a new option for our patients.
Well, thank you all. Thank you again for our first episode. And we look forward to our second episode that we are going to record shortly. So thank you again.
Thank you for listening to SARC Talk Journal Club. If there's a publication you would like us to review or a question you would like us to address, we would love to hear from you. Leave a comment or email sarctalk@sarctrials.org. Be sure to follow the podcast, leave a review, and share this episode with others in the sarcoma community.